Right, I'm Dr. Naveen Mudligiri and I'm a consultant cardiologist with a specialist interest in coronary intervention, and I practice here at Kim's Hospital.
I'm Dr. Peter Kibonga. I'm a consultant cardiologist with specialist training in heart rhythm disorders. I implant pacemakers, defibrillators, and conduct electrophysiology or electrical studies of the heart and ablation where appropriate. I work at Kim's Hospital.
My name's Anne Hatswell and I'm the Cardiology Services Manager at Kim's Hospital. After a lifetime of having a heart rate of 56, my rate is now 90 to 130. This is despite taking beta blockers. Can you explain?
The heart rate is a number that's going to be affected by a number of things. Now, what's not clear from that question is whether there is other medical history we need to consider. Things like your level of fitness will affect your heart rate. Is it possible that perhaps you're less fit than you were before? Is it possible that your blood count has changed? Are you anemic now? Are you taking medications that perhaps will affect your heart rate? We know that some medications will artificially increase your heart rate. But I think the main message to take from this is that the number is not nearly as important as, say, symptoms, what else is going on with your health. So a heart rate of 90 beats per minute can be normal. It can also be abnormal. 56 is normal, but can also be abnormal. So it really depends on the symptoms that you have. If you have no symptoms whatsoever, I would probably ignore the heart rate because it's not as important as how you feel as a person.
So, Dr. Mudligiri, what are the best methods of managing suspected angina?
What's very important, a very common symptom is chest pain, but that could be as a result of lots of different issues. But it's very important that if it is suspected angina, that this is investigated, as it could potentially be quite dangerous. As with all these problems, it's very important to make a diagnosis. And in order to make that diagnosis, it's important that whoever has these symptoms sees a bona fide qualified healthcare professional where they will undertake an extensive review with regard to the questions that they're asked, and they will be quizzed upon their symptoms. And then they will be directed down a series of investigations to try and determine what is the cause of their chest pain. And if it is suspected angina, there are lots of tests that the patient may have to go through. The most basic tests would be an electrocardiogram, which is an ECG, followed by an ultrasound scan of your heart to have a look at the structure and function of your heart and see if there's any obvious abnormalities present. And to really make a firm diagnosis, they would need other tests, particularly to look at the arteries or the blood flow to the heart. And we offer all of those here at Kim's, which could be either a CT coronary angiogram or a gold standard coronary angiogram via the wrist. But as with all of these problems, it's very important to make a firm diagnosis.
Dr. Kibonga, this question is about induction hobs. So this patient's had a pacemaker fitted recently and wonders what changes he has to do.
Where this started is that many years ago, when pacemakers were first introduced, and for several years now, we had this general blanket ban on patients with pacemakers avoiding magnets. The magnet is a key component of the pacemaker. So we know that if you, in theory, disrupt the functioning of that magnet, you may disrupt the functioning of the pacemaker. Now, increasingly, most of the pacemaker manufacturers recognize that pacemakers are so robust that you'd have to have an almost industrial level magnet to disrupt its function. And we do have those. So some of our patients having MRI scans or other such investigations. But even for such patients, we know that if you have specialist input at the time of your MRI scan, for instance, you can still have the MRI scan despite you having a pacemaker. Obviously, every manufacturer will have specific steps you must go through for you to have your MRI scan. But coming back to induction hobs and single organs, the general advice is that if you're going to be working near an induction hob, you step away for a distance of at least 2 feet, because we know about that interaction between pacemakers and induction hobs. But if you were to accidentally do that, there's no need to panic. Chances are the pacemaker would reset to its usual function if you accidentally came within 2 feet of induction hob. And the general advice would be to contact your pacemaker clinic. We certainly have good a good pacemaker clinic here in Kim's. If you have a pacemaker, they'll be able to advise you specifically. Now, with regards to ovens, NEF oven you referred to, or any ovens, there are no magnets in it, so it's safe.
I've had a very few stressful years, and I'm getting very stressed. I sometimes wake up with my heart beating really fast. It slows down if I deep breathe, and it passes after a few minutes. I don't want to take medication. I'm practicing yoga. Is this sensible?
Well, it's important to know that your heart rate does vary during the day and the night, and it's not unusual for that to happen. The vast majority of heart rhythms are not particularly dangerous, but if you are having a problem with your heart rhythm, it's very important that we establish what that problem is. And once we've determined what the problem is, then we can give you a treatment plan as to how we manage it, how we treat it, and how we can sort the problem out. But we have to determine if there is a problem first. So I'd advise you seeing a healthcare professional and getting some heart tests, which may well include monitoring the heart rate and rhythm for 24, 48, 72 hours in order for us to be able to catch what is going on and determine if there is or not a problem here.
I have hypermobility syndrome. Tests including an echocardiogram, a heart MRI show that I have a mildly leaky aortic valve, reduced LV function, about 49%, and an arrhythmia. I'm waiting to see the arrhythmia team, but do I need an ablation?
So the first thing that's not clear from the question is what sort of arrhythmia you have. Arrhythmia is a generic term to mean it may be a heart rhythm disorder, and we have a spectrum of heart rhythm disorders. My suspicion is that you're referring to atrial fibrillation, which is an irregular heart rhythm, which we can't treat with or manage with an ablation procedure. The ablation for atrial fibrillation is the most effective treatment that we have. We have medication for all arrhythmias or heart rhythm disorders, including atrial fibrillation, but specifically with regards to atrial fibrillation, an ablation procedure is the most effective treatment. And the earlier you perform the ablation, the better. What's important to know as well is that in some patients, the arrhythmia itself can have an impact on the overall function of the heart muscle. In other words, your left ventricular function. And I note that you refer to yours being 49%, which is clearly below what we would expect as normal. So 55 and above, we would classify that as normal. So yes, you need to be on a whole spectrum of medications to increase your heart muscle strength. And importantly, if you have atrial fibrillation, I would recommend that you have an ablation, probably sooner rather than later, because we know that the longer you have this, some heart rhythm problems like atrial fibrillation, the more difficult it becomes to treat them. So I'd encourage you to have a conversation with your arrhythmia team with regards exactly what it is you have, so they can explain it a bit better for you. And yes, ablation is potentially a good idea.
Next question. I've recently been diagnosed with pulmonary hypertension, and I'm waiting on an appointment to see a cardiologist, but I'd like to fly to Canada. Is that okay for me to do so?
Well, pulmonary hypertension is a specific problem where the blood pressure in the lungs has gone up. There are many causes of pulmonary hypertension. It may be a problem with the lungs themselves and the vasculature of the lungs, or it could be as a result of a secondary occurrence to some other disease processes, such as some people who've had lots of blood clots in their lungs, or some people who've got a problem with the little air sacs in their lungs, which have become very stiff and what we call fibrotic. It's very important that the diagnosis is first made. And once the diagnosis is made, it's important to establish how severe it is for you. And that would pretty much determine whether or not you require any particular management in terms of tablets or treatments. The treatment for pulmonary hypertension would very much focus on actually establishing the cause of it. It's very important to treat the cause of these sort of issues to try and mitigate further issues. But it'd be advisable for you to have this checked out before you travelled, as it's unclear from the question as to, for example, how symptomatic you are as a result of this problem. And we do know there are all these problems when you're up in an aircraft at 35,000 feet with changes in pressure and oxygen concentrations. So it'd be probably better for you to have that checked out before you travelled.
This patient has proximal atrial fibrillation and wants to get an opinion on the best exercises they can do and should they consider an ablation.
So the exercises we will recommend for atrial fibrillation or any heart rhythm disorders are not really dissimilar to any exercise we recommend in general for anyone who has or hasn't got a heart problem. So anything that increases your heart rate to 70-80% is a good idea. I would generally recommend, for good general heart health, exercising at least 4 to 5 times a week, perhaps 30 to 60 minutes at a time, probably combining sort of aerobic exercising and strength exercising. So if you enjoy swimming, if you enjoy running or walking, and also combining it with something that's going to build your muscle mass. So weights, it doesn't have to be at the gym, it can just be hoovering around the house or carrying your shopping, as long as it gets you breathless, as long as it takes at least 30 to 60 minutes, as long as it's at least 5 times a week. But this exercise regime is not specific for atrial fibrillation. It can be applied across all kinds of heart problems. And specifically about an ablation, yes, ablation is the most effective treatment for atrial fibrillation. For many, many years, we used to advise our patients that perhaps we should try medications first, and if the medications fail, perhaps we can go for an ablation procedure. Evidence over the last 5 years shows that the earlier you perform an ablation, the more effective you get to sinus rhythm, and the less your chances of transitioning from paroxysmal atrial fibrillation, this is atrial fibrillation that comes and goes, to atrial fibrillation that is persistent, it's there all the time. And the reasons for this is because when you go into atrial fibrillation, the atrial fibrillation itself induces or makes your atrium or the top chambers of your heart more stiff, more scarred, and the longer you stay in this abnormal heart rhythm, the longer the scarring occurs. And if at some point, 4 or 5 years, you decide, maybe I should have an ablation, at that point, the success rate has declined dramatically. So paradoxically, at the time when you have the least number of symptoms, that's when you want to get in. The whole sort of stitch in time saves 9 thing is applicable here, because you want to get in as early as possible. Yeah.
Excellent, thank you. I frequently get fluttering in my chest. It's mainly in the morning. However, I do have a feeling of doom and I get tightness in the chest. Is this something to do with my heart?
Well, thank you for that question. And there are a number of symptoms that patients experience. Flutterings in the chest, which we need to determine what the cause of that fluttering is. It may well be benign, but it may not be. And it's important that we catch that fluttering and determine what that is to be able to treat that best. The feeling of doom and tightness in your chest, again, is a symptom that gives me cause for concern. It'll very much depend on the character of the pain, where the pain comes on, how it spreads, how it radiates, are there any associated symptoms with that? And it's also marrying your symptoms along with what we call your cardiovascular risk. Do they smoke? Do you have diabetes? Do you have high blood pressure? Do you have a family history of heart disease? Have you yourself had a previous history of heart disease? And we'll have to use all of that information to determine, or help us determine, whether there is a cause for concern here. But it'd be very important to establish the cause of your flutterings and the cause of your chest pain to determine whether these are actually coming from the heart and what needs to be done about them. And there are a whole host of tests that we can actually use to determine that. And again, that would be along the lines of ECGs, echocardiograms. It could be stress tests to look at the function of the heart, and other tests to look at the quality of the blood supply to the heart, which could be an angiogram performed by the wrist, for example, or using a CT scanner to determine whether there is a narrowing there that gives me cause for concern. And if there is, there are very good treatment options for fixing that. And that would be to try and remove the narrowing that you have using balloons, and also what we call stents, which are metal scaffolds to keep the artery open and helpfully reduce your symptoms as a result of that.
This person has been suffering from atrial fibrillation and has had an ablation done already in September 2020. Now suffering from more episodes of AF. Is it common to have a second ablation, and how successful is it?
Atrial fibrillation is an irregular heart rhythm. It's the commonest heart rhythm disorder pretty much in the world. There is no cure for it, so we should start from there. But there are effective treatments. You can have medication, or you can have an ablation treatment. Now, the problem with doing an ablation is that if you don't do it very early in the course of the illness, then it's not as effective as it is if you do it much earlier on. So to answer your question, it depends on the type of atrial fibrillation you've had. If you've had atrial fibrillation continuously, day in, day out, for years, then most of us who treat atrial fibrillation will quote you a success rate between 40 to 60%. So pretty low, but much better than medication. If on the other hand, you've had atrial fibrillation for 2 years, we can call that persistent, compared to the long-standing persistent example I gave you, then we would quote a success rate of about 60 to 70%. Now, if you have the very short-lived atrial fibrillation, the one that comes and goes, you could have days and weeks without atrial fibrillation. We call that paroxysmal atrial fibrillation. Then we would quote a success rate with an ablation procedure of about 70 to 80%. So that's the highest success rate we can quote. Now, although it's not a cure, we know that ablation reduces your progression from paroxysmal to persistent, and therefore reduces the need for you to have much more complex procedures later on. Now, all these success rates are based on the premise that for about 50% of patients, you will need more than one procedure. So it's not unusual. And the good news is that if you have to have another ablation procedure, which I would recommend, by the way, in this case, is that often we find that one of the veins, you have 4 veins in the top left chamber of your heart, and we know that atrial fibrillation is usually an issue with the connection between the veins, the pulmonary veins, or these are veins that drain blood from your lungs. And there's a thin muscle sleeve that connects the lungs to the left atrium, or the top left chamber of your heart. And within that muscle area, you get these flickers, these abnormal signals that cause atrial fibrillation. And when we do the ablation procedure, we are trying to electrically isolate those signals coming into the left atrium. So we go around and cause little areas of scar, and the areas of scar work like insulation barriers, so the electrical signals can't get into the heart. And sometimes, depending on how your veins are angled, the size of the veins and how they connect, we're all different. Depending on how they connect, you may find a thin area of the scar that starts to conduct electrical signals again. And when we do another ablation, often we will find that if you have 4 veins, perhaps only one vein and only a small area of that vein has reconnected. So what we do is a bit of spot welding. So whilst the original procedure may take 2-3 hours, the second procedure could take us as little as an hour, because there's one area that we need to zap. Now, depending on how far gone your atrial fibrillation has gone, there may be situations where we go in to do another ablation and we find that the veins have still not recovered. In other words, the ablation procedure we did before is still effective. And then we start to scratch our heads and think, what else do we need to do? Now, that becomes a bit more complex. But in general terms, if you've done well for at least 3 years, I would have thought that a second ablation would very quickly help restore sinus rhythm and hopefully keep you of atrial fibrillation for many more years.
Next question. I have idiopathic intracranial hypertension. Am I at higher risk of heart disease, and should my GP be more aware of this and be giving me more tests?
Now, idiopathic intracranial hypertension is not a common condition, and it's a condition which, as it says in the name, affects your brain and not your heart. Okay, in that sort of sense. It's called idiopathic because we don't know the specific cause of it. It's intracranial because it's in your skull, and it's hypertension, so you have raised blood pressure in your brain. There's still a lot of debate as to whether idiopathic intracranial hypertension necessarily increases your overall cardiovascular risk. There are a few studies from a few years ago which have indicated some link between having idiopathic intracranial hypertension and increased cardiovascular risk, but it's not definitive thus far. But what's important to note is cardiovascular risks independent of idiopathic intracranial hypertension are still very common, such as diabetes, high blood pressure, stress levels, high cholesterol, and these are extremely common problems. These problems, whether you have intracranial hypertension or not, need to be identified and mitigated to reduce your overall cardiovascular risk.
Dr. Kabunga, a very topical question. How does that menopause or a lack of estrogen contribute to atrial fibrillation?
This is a topic, unfortunately, that is devoid of a lot of good quality studies or research, but I'll have an attempt at answering it. So in general terms, the highest risk factor for atrial fibrillation on irregular heart rhythm is age. So the older you get, the more likely you are to get atrial fibrillation. Now, with regards to the menopause, we know that the best quality studies, and there's only two I could find, these are prospective studies and long-term studies, both American-based studies. One called the Women's Health Institute study. They have revealed a neutral association between the menopause and atrial fibrillation. But what they have shown, there's a small additional risk in those patients who are perimenopausal, who are menopausal, who take unopposed estrogen. So if you have hormone replacement therapy that's only estrogen-based, then your risk of atrial fibrillation is marginally higher. And that marginal increase in risk of atrial fibrillation is cancelled out if you take progesterone as well. So certainly from an atrial fibrillation perspective, your risk is neutral if you take estrogen and progesterone, and higher if you take estrogen unopposed. The cumulative risk is actually still quite low. As I say, the biggest risk to anyone, male or female, is age. The older you are, the more likely you are to get atrial fibrillation.
How do you recognise the early signs of heart disease?
The signs of heart disease can be quite non-specific. There are a lot of overlapping conditions which can cause a whole range of symptoms which can mimic heart disease. The commonest symptoms that people experience with heart disease could be, for example, as palpitations, and we've already discussed the commonest cause of palpitation so far, of an arrhythmia anyway. There are other symptoms that could be heart-related, such as shortness of breath when you walk, chest pain or chest tightness with exertion. So there are a host of different symptoms that could present as signs of having a heart issue. Patients may also be experiencing swelling, for example, of the legs, which could be a sign of heart failure. Pain in the chest, particular exertion, could be the onset of narrowings of the heart arteries, which is causing them chest pain. So there's a whole range of symptoms that could be quite non-specific to the untrained eye as to whether this is the early stage of heart disease or not. And again, if you have any of these symptoms, I would advise getting them checked out by your healthcare professional to determine whether this is actually heart-related or not. A lot of symptoms, particularly shortness of breath, may well be non-cardiac related. For example, just being less fit, being overweight, and that sort of reason. But it's very important that if you have any symptoms that worry you, that you do talk to your healthcare professional about that.
I have recently been aware of my heart beating. It feels like it quickens and then misses a beat. And it feels like a thudding in my chest. I've had this on and off for a while over the last few months. I've noticed it lasts longer and it makes me cough. And I can feel it in my neck. I can often feel dizzy as well, but I have no pain.
A very common question. I would say in a typical week, I see at least maybe perhaps 20% of my patients with heart rhythm disorders have exactly the symptoms that I described in the question. So I would probably say that the most likely cause of your symptoms is ectopic beats. These are extra heartbeats, usually coming from the bottom chamber of the heart. Now, the way electricity in the heart works is that if you imagine your heart being made up of 4 chambers, you've got 2 top chambers called the atria and 2 bottom chambers called the ventricle. In all of us, electricity travels from a small area in the top right chamber. We call it the sinoatrial node, your natural pacemaker. It then goes to the middle of the heart. There's a junction box there, technically called the AV node or atrioventricular node. And then the electrical wiring distributes the electricity to the rest of the heart. Now, it should move therefore from the top to the bottom. For whatever reason, other parts of the heart may generate an extra pulse of electricity, and we call that an ectopic beat. Very similar to when women have an ectopic pregnancy. You expect that the pregnancy is outside the womb. So it's a normal thing. All of us get these ectopic beats, and they can come from the bottom chamber, the top chamber. If they come from the bottom chamber of your heart, in effect, your heart is being activated from back to front, which therefore gives you the sort of symptoms that I described here. And there are a variety of other symptoms that people may have. They may feel breathless. Some patients may have a cough. They may feel a little bit dizzy. And this is because your heart is temporarily being activated. And another common, temporarily being activated back to front. And another common symptom is that after the extra beats, you feel your heart stopping. Again, that's normal, because once the heart has been electrically activated, it needs a period of time to reset itself. Now, should you worry about these extra beats? Yes and no. I would say 95% of the time, it doesn't really indicate that something's wrong with your heart. But if you think about it, all of us, when our heart is beating, we don't actually feel or hear every heartbeat. But at certain times in our life, I certainly have had it, where you start to be aware that your heart is beating. So it is normal and it is not normal. The problem is that if you start to focus on it very much, you then start to feel it all the time. So I would say, see a health professional, see a cardiologist, perhaps get an ECG. More importantly, an ECG that's going to cover that period of time when you have those symptoms, perhaps a 24-hour ECG. And we will probably discover that you have these ectopic beats that I've just explained. The second thing you may want to do is make sure you have a scan of your heart, an ultrasound scan of your heart, or an echocardiogram. If that also confirms that your heart is structurally sound, then you can be reassured that you're almost suddenly dealing with something that's completely benign. Now, the last point I should make is that occasionally these extra beats or ectopic beats are a sign of other things away from the heart. And this is the body's way of telling you to investigate this. So stress, anxiety, so it's not uncommon for people to have these extra beats at the time of exams or job interviews. And also simple things like, are you anemic? Is your blood count low? Sometimes they're much more common in women around the time of their menses or perimenopausal, or if they're pregnant, and this is to do with fluid shifts in the body. I hope that answers your question.
Dr. Menopause, this patient's had a bypass 2 years ago and wonders what checks they should follow up.
It's important because the burden of cardiovascular disease is huge, particularly in the Western world. It's still the biggest cause of mortality and morbidity in the Western world. And it's very important that we do tackle these problems head on. Now, clearly, you've had a bypass operation before. We know you've got significant disease of the arches of the heart, which is why you've had essentially replumbing of your blood supply. But what's important moving forward is that we mitigate all the risk factors that this patient has to make sure you don't have future problems. We need to keep the grafts well. We need to keep your heart as well as we can. And that would be basically individualizing the patient's treatment plan moving forward. And that would mean monitoring the patient's blood pressure, making sure that's well controlled and within normal range. As we know, high blood pressure is one of the biggest causes of heart disease in the country. If you're diabetic, to make sure your diabetes is under control. That's a huge risk factor for ongoing issues moving forward. Again, we need to make sure your cholesterol is well controlled, and we have specific target ranges that we expect people to meet, particularly if you've had heart issues already. So we're very strict about the bad cholesterol in your blood. That's what we call the LDL cholesterol. So we need to be really strict about what levels you're getting. And if you're not getting them, we need to make sure you're on the right treatment options to bring that down back into the targeted guideline range. And there's also other factors such as your stress levels, to make sure you mitigate your stress levels moving forward, to make sure it doesn't alter your blood pressure too much in that sort of sense. There's little we can do about your genetic background if you have a strong genetic risk factor for heart disease. Unfortunately, there's nothing at this stage that we do to mitigate that, but it's important that if you have it, we mitigate all the other risk factors as much as we can. So going forward, you need to make sure your blood pressure is checked, your weight's under control, you're performing what we call the appropriate secondary preventative therapies, exercise, dietary measures, lifestyle changes, and sticking to the tablets that you're on. And we often offer this to patients who've had bypass surgery or stents or even heart attacks. It's an extensive program of cardiac rehabilitation. And it's important that people who have had heart surgery, such as yourself, in the question, undertakes this program, because we know those people who enter these programs are more likely to have better outcomes as they're more judicious about their blood pressure control, about what they eat, about making sure how they exercise, and sticking with the tablets that they're given.
I have great concerns about non-sustained ventricular tachycardia. I have been found to have a few episodes on the recent 7-day monitor. I have a structurally normal heart after an echocardiogram, and I'm pre-menopausal. I wonder if this is causing the palpitations.
Now, I'll start off by saying that if you have a structurally normal heart, you automatically go into a good prognostic group. Now, I don't know very much about the rest of your medical history, but assuming that there isn't anything else in your medical history, then what I would say is that a lot of us get these episodes of non-sustained ventricular tachycardia. And the non-sustained ventricular tachycardia has to be taken into the context of not only your personal history, but also your family history. So if you got people off the street and say to them, look, I'm going to put a 7-day ECG on you, I would guarantee you would find a lot of very healthy people with these episodes of non-sustained ventricular tachycardia. So in itself, in isolation, I would not get concerned, especially if your heart is structurally normal. Now, there are a few patients, again, depending on your own personal history or family history, where we would want to upgrade the number of investigations we do. We may want to consider perhaps putting you on a treadmill to try and stress your heart out. We may want to do an MRI scan of the heart to make sure that there isn't X-ray information that we will find that will be useful. But assuming there's nothing else going on in your own personal and family history, then yes, it is possible that being perimenopausal can generate these extra beats, which may come from the bottom chamber of your heart or the top chamber of your heart. In my experience, some of my patients who have gone into hormone replacement therapy have had benefit. Obviously, you would need to discuss this with your specialist. But during the recent pandemic, there were some shortages in HRT, and even in some of my patients who had a change in the preparation of HRT they were getting, when they came to me with palpitations, we would find a variety of these extra beats, either extra beats coming from the bottom chamber of the heart or top chamber of the heart. And once the market was restored and people could get access to their normal HRT, these symptoms vanished. So we know that they were not in themselves dangerous. But for whatever reason, we know that estrogen and progesterone can have an effect on the way the electrics of the heart are generated and conducted. But having a structurally normal heart with an echocardiogram suddenly puts you in a very good prognostic group. So I wouldn't be particularly worried, assuming nothing else is going on.